Hello everyone, welcome to the White Army Comprehensive Clinical class. The White Army is blessed to have Dr. Akila ma'am, Assistant Professor from Sri Padmavati Medical College, Tirupati, as our mentor today. A very warm welcome to you, ma'am.
Yeah, thanks a lot, and it's my pleasure to be here again with you all, yet with another case discussion.
Yes, ma'am. Ms.Thanusha, fourth year MBBS student from AJ Institute of Medical Sciences, Mangalore, has volunteered to present a clinical case on gestational diabetes mellitus today. Welcome to you, Ms. Thanusha. I welcome all the attendees to the session. With our mentor's permission, we shall begin the session.
Yes, please. We shall begin the session.
Good evening, ma'am. I'm Thanusha. I'll start.
Can you please switch on your video?
Ma'am, there is some network issue from her side, so that's why she's not switching it on. Is that okay, ma'am?
Yeah, that's fine. It would be better interactive session if the presenter is seen, no?
Yes, ma'am.
Like if still you can't see, then that should be fine.
Okay, ma'am. Thanusha, you can try switching on the video. If there is any issue, then you can switch it off then.
Wait, is my video seen?
Yeah, it's seen.
I'll start.
Yeah, Thanusha, start.
Presenting before you a case of 24-year-old Mrs. XYZ, hailing from Kinigoli, who is a homemaker and she studied up to 10th standard. She is the wife of Mr. XYZ, who is 33 years old, who is a contractor by occupation, and he too has studied up to 10th standard. The socio-economic status is upper middle class. Her obstetric score is Gravida 1. Her last menstrual period was on 29th January 2021. Her expected date of delivery is 5th November 21. Her period of gestation is 34 weeks 4 days. Her blood group is O positive. She was admitted on 24th September 21 and examined on 24th September 21.
Thanusha, do we write blood group in the introduction?
Yes.
You guys write it routinely?
Along with demographic details.
Do you write it routinely for all cases?
No, in case like if it's a negative blood group usually. I mention the husband's blood group.
It is not put in demographic profile. See, according to what your college is doing. I mean, at least we don't ask our students to put it in a demographic profile. Carry on.
Okay. Chief complaints. The lady comes with 7.5 months of amenorrhea and was admitted for antenatal care in view of high blood sugar level.
Yes.
History of present illness. A primigravida patient with 7.5 months of amenorrhea came for her regular antenatal checkup and was found to have high blood sugar, and she was admitted. There was no history of increased hunger, thirst, or frequency of micturition, no history of fever or rashes, no history suggestive of recurrent UTI, no history of abdominal pain, no history of vaginal discharge, no history of skin infections.
1 second, stay back there in that slide. Why did we ask history of increased hunger, thirst, frequency of micturition?
Why did we ask?
What is the relevance of each negative history of whatever you have asked?
Okay. Yeah. In case of diabetes, there will be increased thirst, polydipsia, polyuria, and even increased hunger to rule out if preconceptionally she was diabetic. And then no history of fever or rashes. This is to rule out any infection.
Are diabetic more prone for infection?
Yes, ma'am. What?
Are diabetic people more prone for infection?
Yeah, it's one of the maternal complications. Like,
why are they more prone?
Because of the high like glucosuria, there's increase of asymptomatic bacteria or any UTI infections.
Okay. Then, why did we ask about the pain abdomen?
Pain abdomen in case of don't know, any infection.
In the abdomen. Okay, see, whenever we write something, we should be able to justify why we have done it. Probably, like according to you, she's 34 weeks, right? Probably because of polyhydramnios, she might be having some discomfort, if at all. Because diabetic people are more prone for polyhydramnios. No, see, there is not. Okay, somebody is telling labor pains. Yes, definitely. She can present to you with preterm labor. Whenever we write something, there is nothing called right or wrong. We should always be able to justify what we are telling. Okay. Next.
Okay, no history of vaginal discharge to rule out any
What
vaginitis.
types of vaginal infections are diabetic people more prone for?
Candidiasis.
Very good. Next.
No history of any skin infection.
Skin infections. Okay. Next slide.
slide. History of present pregnancy. First trimester, it was a planned pregnancy. Urine pregnancy test was done at 15 days of her missed period and was found to be positive, which was confirmed by scan. Folic acid tablets were started preconceptionally. There was a history of white discharge per vagina. There was a history of increased frequency of micturition. No history of nausea or vomiting. No history of fever with rash, easy fatigability, spotting or bleeding TB, pain abdomen. No history of burning micturition. There's no history of radiation exposure or drug intake.
Okay. Do you think this increased frequency of micturition is related to diabetes?
In first trimester, it's physiological, ma'am,
Why?
because the uterus is growing in size and it might put pressure on the bladder, and then also because of progesterone, like later on release, it's a relaxing, so this
Majorly because of the pressure of the uterus, growing uterus of the
bladder.
bladder and urethra. So she'll have an increased frequency. She feels like she has to go again and again. Okay. Next. So this is nothing related to your diabetes. It can be if she were to be over diabetes and now you have found it out. If she did not have a regular antenatal checkups, but apparently history seems that she's smart enough. It was a planned pregnancy and she even had taken preconception folic acids. So most probably it looks like a physiological change. Correct?
Okay. Yes.
Next.
Okay. Second trimester, quickening was felt at 5 months. 2 doses of tetanus toxoid was given at fourth month and fifth month. Iron and folic acid tablets taken. Calcium tablets were also taken regularly. Anomaly scan was done at fifth month, showed normal report. She came for regular health checkup and was diagnosed to have gestational diabetes mellitus and was put on insulin. She was non-compliant in taking the insulin as she didn't know how to inject it. There was a history of increased frequency of micturition, no history of fetal edema, blurring of vision, headache, epigastric pain, decreased urine output. There was no history of bleeding TB or leaking TB.
1 second. So, like in your history, she got to know that she's diabetic in second trimester, correct? Just a second. Am I audible, Tanusha?
Yes, ma'am. Audible, ma'am.
I just got a hospital call. Sorry for the interruption. Yeah, continue. Okay, what were we discussing? Like she came for regular checkup and she was diagnosed to have gestational diabetes. Okay, like when you are mentioning this, no, it's always preferable you mention the gestational age at which this was diagnosed. Now this, like, how do we divide trimesters?
Okay, first trimester is up to 13 weeks plus 6 days. Second trimester starts from 14 weeks up to 27 weeks plus 6 days. And third trimester is beyond 38
Okay,
weeks.
so your thing is ranging from 14 till almost 28 weeks, correct? Generally, when do we expect GDM to develop? Generally.
Beyond 24 weeks.
Absolutely. So we'll usually expect, if at all it is GDM, then it has to develop between 24 to 28 weeks. That's what we expect. That's what the pathophysiology says, right? So in that case, in your entire second trimester history, she could have been diagnosed at 14 weeks or she could have been diagnosed at 28 weeks, correct? So it's preferable you write an average gestational age when she got to know that she was diabetic in the history. Okay. And she was put on insulin. That means to say, like probably her values were high, that they did not even try MNT, correct?
Yes. That's what she told. They started insulin. MNT plus insulin.
Okay. Do you think in first trimester, it's important to get an NT scan for her or for any lady for that matter?
NT scan, ma'am.
NT
Neural
scan.
transparency.
Scan.
Yeah, because there's increased, like, because of ethnicity, like universal screening is also done, or like all pregnant women have a higher chance. And neural tube defects are like, it's specific in.
Get her NT scan done in her first trimester? NT.
She said scan was done, ma'am. Like, couldn't.
Do you think it was an NT scan or a dating scan? See, what are the two scans we get? We do in the first trimester.
6 to 8 weeks dating scan is done.
Correct.
And then 11 to 13 weeks nuclear transparency scan is performed.
Very good. So it's important for this lady to have got NT scan in that 11 to 13 weeks, 6 days window. Okay. Yeah, go ahead.
The third trimester, continue to perceive fetal movements. Iron and calcium tablets continue. Growth scan was done and was reported normal. She came for regular antenatal checkup and was found to have increased blood sugar level. There's a history of irregular intake of insulin.
One second, Tanusha. Here, she came for regular antenatal checkup. You already know that she has an increased blood sugar level for which she is not taking insulin properly, correct? So you already have been labeled her as GDM in the second trimester itself. I mean, at least she knows it.
Yes.
Okay. So you can rather put it as came for antenatal checkup and her blood sugars were not under control since she was not taking her treatment regularly. Okay.
Yes.
See, we have not found it out newly. We already know that she's diabetic. You got the difference? What I'm trying to tell you. Okay.
Yeah. Yes. There's no history of blurring vision, headache, epigastric pain, or decreased urine output, or swelling of teeth. There's no history of bleeding or leaking for PV.
Very good. 1 second. No history of blurring of vision, headache, epigastric pain, reduced urine output, swelling of bit. Why did we ask?
Another complication is the pregnancy induced hypertension, preeclampsia, like just to rule out.
Do you think GDM, I mean, we have just asked as a part of history, or is there any relationship or association between GDM and preeclampsia?
Yes, ma'am. Preeclampsia is a maternal complication.
No, is it something like GDM patients are prone for developing preeclampsia or they can develop preeclampsia, something like that is there?
Yes, ma'am. It's a complication they can develop, and it's also like her irregular intake of insulin also like.
So she can also develop preeclampsia along with GDM. Okay. Good, Priya. Okay. So there is no history of bleeding or leaking PV. Bleeding or leaking PV. Now we know that her trimester is 34 weeks, correct? So do you think leaking PV is common in her than general antenatal population?
Leaking, yeah, because like they have a risk of preterm labor.
Why?
It's a complication.
See, everything is a complication or a cause.
Premature rupture of membrane.
And that is what? PROM. She can have PROM being a diabetic, correct? Why? Diabetic GDM is one of the risk factor to have PROM. Very good. Because it can be because of subtle infection which we don't know, or it can be because of polyhydramnios, as your audience are putting in the comments. Okay. Correct, Priya. Go ahead.
Okay.
And what do you think is the reason for bleeding PV at this gestational age? Think that she
maybe abruptio placenta.
Probably slight spotting or whatever it is. What do you think is the cause?
Can be antepartum hemorrhage, abruptio placentum.
Okay, one thing can be
placenta's place.
What kind of APH can she have?
Abruptio placenta.
She can have abruptio placenta provided if she also had a history of PIH, correct? One possibility. Okay. The other possibility is?
I don't know.
Can she have placenta previa or a low-lying placenta or something like that?
Yes.
Yes, Yukta, right. She can also have placenta previa. Why? Because of the placentomegaly, that is a large placenta, some part of it could have been implanted in the, could have been attached to the lower segment, which will present to you as low-lying placenta. Could be. Can it be a possibility? My question is, can it be a possibility? And third thing, what we can think of is she might be going into preterm labor, wherein she is coming to you with pain abdomen and show and leaking PV. Could it be a possibility? Yes. Good. Go ahead. Go ahead.
Menstrual history. She attained menarche at 15 years. She has a regular 28 day cycle with 5 days flow. She changes 2 to 3 pads per day. There's no history of dysmenorrhea or menorrhagia. And the last menstrual period was on 29th January 21. Then marital history. She's a primary gravida, so there's no obstetric history.
1 second. Just hold on here. Like in the history, do you think asking the history of increased weight gain during that particular pregnancy is important?
Increased weight gain. Yes, ma'am.
Correct. I mean,
Because
do we need to ask that? Increased weight gain?
Yes, ma'am.
Generally, what is the weight gain we expect in a particular pregnancy?
If pre-pregnancy, like the BMI was within normal range, then about 12 to 16 kg.
So around 12 kgs we can expect. So these people can be more prone for increased weight gain than 12 kg, correct? Why is it so?
Because of increased fat deposition, hyperinsulinemia.
Okay, because of big baby rather. Okay, normally a lady would have an average size baby. These people are prone for macrosomia. That one thing can contribute because of polyhydramnios. Yes or no? Yes. All these things overall contribute to increased weight gain during pregnancy, which is better if we ask it in the history. Okay. Now, I will, for a moment, I will consider her as G2P1L1. Okay. Gravida to para and living one for the discussion sake, for the benefit of a larger audience. What all is important for you to know, and know, always I tell my students, you people should be very smart. So keep your obstetric scores minimal so that the discussion won't be more. And you are smart, Thanusha.
No, she's just 24 years old. She got married at 20, so this is her first pregnancy.
Good. I always tell my students that, like, if at all you are writing a dummy case, please keep things minimal so that the discussion will be straightforward. Okay. Anyways, for the benefit of larger audience, take it as gravida to para 1 leading 1. What all previous obstetric histories are relevant to you in this case?
If she like previous history of gestational diabetes,
If she had previous history of gestational diabetes in the previous pregnancy, good. Then
large baby or difficult delivery or any still, is she L1, ma'am?
L1, yes.
If there was previous abortion also history, then
okay, you would like to know previous abortion histories. Okay, and you would like to know her birth weight, as you said. Okay, and somebody, Pallavi, wants to know if it is the mode of delivery. Very good, Reshma. And you would like to know if there was any complications in the puerperium. Then, good. Active participation from the audience. Very good. Then, what all you still want to know? Okay, I'll tell you the history, whatever you wanted. Yes, she was GDM in her first pregnancy. See, because no, always we will not pick primary gravida in your cases. So, if at all it happens to be a real case and she was G2P1L1, all this history becomes important to you. So, you should know what to ask. Okay. Yes, she was diabetic, which was diagnosed at 26 weeks in the previous pregnancy. What else you want to know?
To rule out any like blurring of based on history, ma'am, and even past history. There's a strong
somebody told
diabetic history in the family.
Okay, you would like to know a diabetic family history? Is fine. Very good, Reshma. Treatment history you want to know. Correct, no? Whether the thing was controlled on MNT or she was put on insulin at any time in the previous pregnancy. Would you like to know that?
Yes.
Yes, we would like to know that. Then, what else you would like to know in the obstetric history? She was on insulin. Okay. Then, what else you want to know?
In the if it was eventful, like the antepartum period.
Okay, you would like to know if she has also developed any other complications like preeclampsia or antepartum hemorrhage, something like that. Correct?
Yes.
Yes. Good. No, she did not have any of them. Even her Leica volume was normal. What else you want to know?
Then, whether in the was it a preterm pregnancy? Then, whether in the intrapartum, postpartum,
to know the timing of delivery, whether it was term or it was induced before or spontaneously went into preterm. Very good. She was term.
And then, was there any postpartum hemorrhage, like post?
I mean, correct, Reshma. Baby weight in the intrapartum period. Let's discuss intrapartum things. What do you want to know? Mode of delivery, birth weight of the baby, then
any like PPH, postpartum hemorrhage, or preterm pregnancy.
Okay, still, I mean, before that, a step before that, would you like to know whether there was difficult delivery, instrumental delivery, or like you took up a cesarean section for any other reason? Was there any cephalopelvic disproportion? If it was vaginal delivery, like if you have used any instrumentation, or whether the delivery of the entire baby was smooth, or whether the baby, whether the lady had shoulder dystocia at that time, how was it relieved? And following that, as you said, whether there was any atonic PPH or traumatic PPH, all these things becomes important. Correct? Then, what else you would like to know in the obstetric history?
Like whether same thing, like preterm, premature rupture of membrane, any preeclampsia, the position of the placenta.
No, all that is over, no? We are still in the obstetric history. What more details would you like to know?
Like
weight gain in the mother. Okay, we are already in the process of delivering her, no? Okay. So whether you have breastfed the baby, whether the baby had any neonatal complications, whether the baby was admitted in an NICU, whether it had any brachial plexus injury, don't you think all those are important?
Yes.
Yeah, breastfeeding history has to be taken. Somebody have put it as lactation failure. Yes, that has to be found out. Now you got to know, like if you get G2P1L1, what all histories you have to ask in the previous obstetric history. You should again ask a brief note on antenatal history and intrapartum history and post-delivery history. Got it? And new perinatal things also you need to ask. If nothing is there, well and good. If something is there, you need to find out and mention it. Okay. And also again space in between these two pregnancies. What did she use? That has to be mentioned if it were to be multigravida. Okay. Go ahead.
Marital history.
Yeah. Next slide.
Okay, next slide. Past history. There's no history of diabetes mellitus, hypertension, asthma, tuberculosis, thyroid illness, or epilepsy. No history of surgery or any medical intervention.
Next slide.
Family history. There's no history of similar complaints in the family. No history of twin pregnancy in the family. No history of children with congenital anomalies or malformations. There's no history of diabetes, mellitus, hypertension, asthma, tuberculosis in other family members.
Okay. Do you think family history is important in this case?
Yes, ma'am. Like if there's a strong family history of diabetes, then that's a risk factor for GDM if she wasn't overt pregnant.
Yes. So
then,
any parents having, aunt, uncle having, any or siblings having, she will have a higher predisposition towards development of GDM. Okay. There.
And then congenital anomalies, it's more common in overt diabetes. So just to rule out like
very
family
good.
history.
Then.
And then
any
comorbidities like hypertension, asthma.
Okay. History of congenital anomalies becomes very important.
I didn't get the question.
History of congenital anomalies becomes very important in her own obstetric history, family history. Yes or no?
Yes.
Yes. Okay, next.
Okay, personal history. Patient consumes mixed diet based on 24-hour recall method. Morning, 5 idli, 1 cup sambar, 1 cup coffee. In the afternoon, 3 cups rice, 2 cups sambar. Evening, 1 apple, 1 cup milk. Then night, 3 cups of rice, 2 cups sambar. Okay, her calories required is 2,500 kilocal. Her deficit is 2,100 kilocal. She has a normal appetite. There's adequate sleep. Her bowel and bladder habits are regular. There's no substance abuse and there's no known history of drug allergy.
Okay, you think deficit is 2,100 calories? She's taking only 400 calories. Do you really think so?
Based on the calculation.
Okay, that has to be checked. Okay, next. Next.
General physical examination.
See, having so much of deficit, by 34 weeks, she already has a weight gain of around 11 kgs. Can it be possible?
No.
So that should be checked, okay? Okay, but depending upon her BMI, where she fits into in the BMI scale?
She's in the overweight category, 26.
Overweight category, very good. What's normal BMI, which we take it as?
18.5 to 24.9
Very
per
good.
meter.
Overweight?
More than 25 up to, based on Asian BMI, like Southeast Asia, it's up to 25. No, I'll tell WHO. Based 25 to 30, ma'am.
Yeah. Obese?
More than 30 kg per meter.
So what is the recommended calorie intake depending upon the weight? Since you have presented about dietary history and weight, we'll complete that discussion at this place. What's the recommended calorie intake? Normal BMI.
Normal BMI, it is like 25, 35 to 40 kilocal per kg per day. It has to increase.
Okay. So benefit of everybody, normal BMI usually recommended intake is 30. Remember it as 30. Overweight around 25. Obese around 20. The more the weight, lesser the food we give to them. Got it? Then next, go ahead.
Patient is moderately built and well nourished. Her pre-pregnancy weight was 65 kgs. Present weight is 76 kgs. Her height is 159 centimeters. Her BMI is 26 kg per meter square. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema are absent. Thyroid, spine, breast examination appears normal. Her vitals, pulse is 89 beats per minute. Her blood pressure is 115 by 80 millimeter mercury. Her respiratory rate is 24 breaths per minute. Temperature afebrile. Systemic examination. CVS, S1 and S2 heard, no murmurs. RS, normal vesicular breath sounds heard, no added murmurs. CNS, there's no neurological deficits. On per abdomen examination, inspection, shape of the abdomen, it's longitudinally and uniformly distended. Corresponding quadrants move equally with respiration. Flanks are not full. Umbilicus is central and everted. Linea nigra and stria gravidarum are present. No visible incisional scar, sinuses or dilated veins present. Anal orifices are intact. Palpation. Fundal height corresponds to gestational age, 34 weeks with no fullness in flanks. Symphysiofundal height is 34 centimeter. It corresponds to gestational age. Abdominal girth is 106 centimeters at the level of umbilicus. There is increased liquid. Fetal weight is 3.441 kg. Leopold maneuvers, fundal grip. It is broad, soft, irregular mass, which is suggestive of breech. Lateral pelvic grip, right side, it's irregular, multiple knob-like structures, it's suggestive of limb butts, and on the left side, it's a continuous curvilinear resistance, suggestive of spine. First pelvic grip, it is hard, round, ballotable mass felt, suggestive of head. Second pelvic grip, fingers are converging, head is not engaged. On auscultation, fetal heart sound is heard in the left spino-umbilical line. Summary.
Yes.
Summary.
Yeah.
A 24-year-old primary gravida patient married since 4 years with no history of diabetes mellitus in preconception period. On examination, fetus corresponds to gestational age in cephalic presentation. There's increased liquor. She came for a regular ANC checkup and was found to have high blood sugar levels and was started on insulin.
I would rather put this as 1 second. Sorry for the interruption. Yeah, can you hear me? Thanusha? Thanusha?
Ma'am, you're audible, ma'am.
Yes,
Yeah.
ma'am, I can hear.
Yeah, okay. So I would rather put it as 24-year primary gravida, married since 4 years, who was diagnosed to have diabetes in second trimester, was started on insulin, was not compliant to treatment, has come for antenatal checkup with no positive family history or with no positive family history. Then on examination corresponds to the gestational age in cephalic presentation associated with increased diaper. Now has come for, see, this history part and examination part are clubbed. Can you see that? Initial part is history, again examination, and again history part has come. Correct? No. So you can put the entire history part in one place, followed by your examination part. So what you can tell is her age, primary gravida, married life. Okay, that is fine. When was she first diagnosed to have GDM? In the second trimester, right? So you can put it as she was diagnosed to have GDM in second trimester, for which she was advised insulin, but she was non-compliant to treatment. Now came to OPD with raised blood sugars.
Yes.
And then you can write your examination findings. That would be more orderly, correct? No? If she has any positive
Yes.
past history or a family history, that also can be added in that history part of the summary only, right? Now,
Yes, ma'am.
you have almost covered everything, but just a small alignment. Fine. Next.
Provisional diagnosis. A 24-year-old primigravida presents at 34 weeks, 4 days of gestation with a single live fetus in longitudinal line in cephalic presentation with gestational diabetes mellitus on insulin.
Now you have started her on insulin.
Yes, ma'am, in second trimester.
Do we have to admit her? No. On in second trimester on insulin, but which she has not taken, right?
Yes, ma'am.
Yeah.
On
So with gestational diabetes mellitus, not on regular treatment. Okay. She was advised insulin, but she's not taking it, no?
taking but non-compliant. Yes, ma'am, not regular.
That you can put it. And also that with polyhydramnios also is there, no? According to your clinical examination, that is not mentioned here, right? That also can be added. Fine.
Ma'am,
Okay.
is it okay if I switch off the video because your voice is like, for me, it's cracking a bit, starting to crack.
Okay. Can you shift to a better network place? See, if I don't see you now, I'll not understand. I mean, whether my thing is reaching you or not.
I'll keep it on, ma'am. Just let me know if I get disconnected.
Yeah. Fine. So now, what do you want to do with her? What's your further plan of management?
Hospitalize, admit her, ma'am. Because
Okay.
she's already.
Admit her. Correct. Then.
And then routine investigations just to keep her blood glucose level in check.
What all investigations you would like to do?
Routine investigations are like the blood group, then RH compatibility, urine analysis for any infection, proteinuria, and then even this with consent HIV testing, VDRL, HbSAg, and then complete blood count, hemoglobin level, and blood sugar levels, and any trisomy scan if needed.
Hmm. Would you like to do PV? I mean, somebody is asking PV. Would you like to do PV?
Yes, ma'am.
Provisional examination. When she's not complaining of pain abdomen, when on examination your uterus is relaxed in the patient, do you still like to do PV?
Oh, yes, ma'am. If there's any premature rupture of membrane or leak.
He's not complaining anything, no?
I don't know.
Not necessary. Okay. Unless she's complaining of pain abdomen or something, not necessary. Fine. You can do perspectrum examination to look for vaginal infections and treat accordingly. Fine. Okay. So now she's almost 35 weeks, nearing 35 weeks, and she's not on insulin. So what all are important for us now?
She's 35 weeks and
She's already 35 weeks. She already has polyhydramnios, and most probably because she already has polyhydramnios, she might have macrosomia also for that given gestational age. So how do you want to proceed further? You want to admit her, you want to send for investigations. Then what else you want to do?
continue with the insulin therapy, because she's
Okay.
already hospitalized, it's easier to administer and keep her
Okay.
And then the estimated fetal weight was 3.4, so that is fine. Like, and she has no comorbidities like hypertension and all. So keep continue with the medical nutritional treatment and this one insulin therapy in the hospital.
Okay. Do you think once somebody has started on insulin, again now there is a role of medical nutrition therapy or just a dietary modification?
This dietary modification, like
Yeah.
insulin alone won't be
You can
helpful.
advise a diabetic diet, but that will definitely not be the sole treatment for her, right?
Yes.
Yeah, next.
And then if she's just 35 weeks, usually by term like 37, or like if she doesn't go into labor.
Listen, let me give you a leading question. When do you want to terminate her pregnancy?
So by 37.
Options 37, 38, 39, and 40.
Both 37 weeks.
37 or 38? 38 weeks. Somebody has rightly pointed out 38 weeks. Okay. I would like to take her till 38 weeks. I would like to keep her under continuous surveillance. First, maternal surveillance, as you already mentioned, and then fetal surveillance. What all fetal profile I want to, because I think we are almost, we are 650. Now I'll just tell you. And
why do we stretch it to 38 weeks? Is it 37 to 38 or stretch it up to 38?
38. If no other complications, 38.
Yes.
Okay. Why 38?
I don't have.
Anybody from the audience? Very good. Lung maturation. See, if it were to be preeclampsia, we would have done it at 37, around 37, between 37 to 38 weeks. But in diabetes, we will take a week more because lung maturation is an issue in GDM. Why do you think children of infant of diabetic mother has a less lung maturation? What's the mechanism behind it?
There is chronic maternal hyperglycemia. So there's fetal hyperglycemia too. And then fetal beta cells undergo hyperplasia, hyperinsulin, and that reduces the surfactant production.
So finally, what is the thing? Like there will be surfactant deficiency coming from the fetal lungs, correct? Okay. So what do you do to prevent that?
Give dexamethasone to improve the lung maturity.
For dexa or beta?
Dexamethasone.
What are the two options available for improving lung maturity? Fetal lung maturity. What are the two options?
Like any steroids, dexamethasone can be given.
Very good.
Betamethasone.
Dexamethasone and betamethasone. Okay. Injection dexa and injection betamethasone. Okay. See, that point should have been mentioned. After your glycemic control, it is important for us to give her steroids for her fetal lung maturity and then only plan for the mode of delivery in that particular pregnancy. Okay. So, how is betamethasone given? Injection betamethasone 12 mg, 2 doses, 12 hours apart. Okay. Injection betamethasone 12 mg, IM, 2 doses, 24 hours apart. Sorry, I told 12, no, 24 hours apart. 12 mg, 24 hours apart, 2 doses, injection betamethasone IM. If it comes to DEXA, we give 4 doses of 6 mg each. Okay, total dose is 24 mg only, but then just the dosage varies. If it is beta, it is 12 mg, 2 doses. If it is DEXA, it is 6 mg, 4 doses. That's it. Fine. Okay. This is about steroids. So, like, how would I like to proceed this case? I will admit this case and I will monitor her. As you said, routine investigations will say what is important to me. As you said, urine routine is important to me, to look for proteinuria and infection and treat if at all there is any infection. And renal function test is important to me. Yes or no?
If she was overt diabetic.
Otherwise, also for GDM, also I would look for RFT. Right? Over diabetes, it has more significance to look for if she's developing any end organ problems or if she's going into any vasculopathies. Okay, then this will be a part of maternal surveillance under sugar control and sugar monitoring. And as you said, we will rightly start her on insulin because she's already advanced gestation and she has not responded probably to MNT. What are the three cornerstones of treatment? Diet, physical exercise or lifestyle modification, and pharmacotherapy. Correct? Okay. So what is the lifestyle modification we would tell her? Though it might not be very helpful at this gestational age now, but what is the modification you would like to tell her?
Like life based on diet and exercise. Diet, like to divide her meal like 50% carbohydrates, 25% protein, 25% fat, and then 3 meal regimen, and then with 2 snacks. Not to have too much at one go, like split it. And then exercise, 30 minutes exercise, maybe brisk walking,
Very good.
5 times a week.
Very good. So as you said, we will give her dietary advice and lifestyle modification advice in the form of physical exercise. And as you have rightly put it, 30 minutes a day brisk walking for 5 days a week is preferable. Okay. Then coming to the diet, you will divide it into 3 major meals and 3 snacks.
Yes.
And you will calculate the calories according to what was discussed previously, and then you will divide it into these 3 major meals and 3 snacks. Correct? Okay. So around 50 to 60% of it will be your carbohydrates. So what kind of carbohydrates you want? Simple direct carbohydrates or complex carbohydrates?
Simple.
Simple.
So complex, so that it takes time to break it down.
Very good. You would advise complex carbohydrates. Fine. Like fruits, vegetables, nuts, anything. Not just ORS water or glucose water or something which is direct. Fine. You will advise her 50 to 60% of the carbohydrates, majorly comprising of your complex carbohydrates, high fiber diet than a starchy diet. Then around 20% of your protein. Okay. Which should be minimum around 1 mg per kg. Okay. Then fat should comprise around 20 to 30% of the fat, out of which less than 10% should be your saturated fat.
Yes.
Correct, no?
Yes.
So, why are we dividing? What is the funda in dividing her diet into multiple things?
So that she has a balanced diet.
So, she has a balanced diet. I will eat everything in the morning.
Division.
Now that is intermittent fasting is fashion, no, amongst medical students. They won't eat for 16 long hours, right? I will also suggest that only because my students do that.
Like for her, it's better to have multiple meals with right amount of calorie intake than one large meal or
Divide
2
her
large meals in a day.
calories. Yes, very good. You want to divide her calories into 3 major meals and 3 minor snacks because you want to maintain her glycemic status relatively constantly throughout the day. Okay. See, now, like if in the second trimester she had come to you, you could have started her on MNT and you will follow her up for 2 weeks. If following 2 weeks, her blood sugars are under control, you will again continue MNT for subsequent 2 weeks. Again, you will call for follow-up. If her blood sugars are raised after 2 weeks of lifestyle modification and medical nutrition therapy, then you will start her on insulin. Get that? Now, because it's already 35 weeks and you are expected to deliver the baby in coming 3 or 4 weeks, so you would like to put her on insulin depending on her values. So how do you monitor her blood sugar? Okay, this is about maternal surveillance. I'll come back to that. And now let's know how do we look for the fetal surveillance? What all we do to look to know if fetus is doing good or not?
Past 32 weeks, bi-weekly non-stress test can be performed, and USG also to check for the amniotic fluid changes, any infection. If needed, biophysical profiling, but usually it's USG and non-stress test.
Will suffice. Very good. Is there anything I would like to tell the patient?
For fetal.
Is there anything I would like to tell the patient regarding fetal surveillance? I want to know if the baby is doing good or not. Is there any advice I would give to? Very good. Perception of fetal movement. Okay. Perception of fetal movements or daily fetal movement count is one thing wherein which I would like to cardiac kick count. Can you see all the inputs from all your friends?
I
So
haven't. Yes.
You can see you are in Zoom only, no? Yeah.
Yes.
Daily fetal movement count or daily fetal kick count is one thing which we would like to look, advise our patients to look, I mean, for them to perceive if the baby is doing good or not. From the objective point of view, as you have rightly pointed out, we will like to do investi from starting from 32 weeks of gestation. Correct? We will either do weekly or bi-weekly depending upon what you want or depending upon the patient profile and associated complications. Okay. And as you have rightly put it, we will also do a antenatal scan or an ultrasonography. So what all is important for me in USG?
The position of placenta and then the amniotic fluid. Any changes?
Okay, amniotic fluid, position of the baby, then
Fetal presentation, like confirm it once.
somebody is putting AFI, placental position, then
That's all I do.
what is most important? Are we not concerned about the baby weight?
Yes.
Are we concerned about the, see, what is the major, one important complication or sequela of GDM we know?
Macrosomia.
Macrosomia. So how do I know that? Just by seeing, how did you
Abdominal circumference,
410?
you can test. Or the previous one I used Johnson's formula, ma'am. If you're doing USC, abdominal circumference is useful for.
Yeah, yes. So we take 4 parameters and the software itself calculates EFW. What are the 4 parameters we take in a scan to know EFW? Estimated fetal weight?
The symphysis fundal height.
No. In the scan.
Oh, scan.
Okay. What are the 4 parameters we consider is BPD, that is biparietal diameter, head circumference, abdominal circumference, and femoral length. Once you measure all these 4 things, by itself, computer will give you the estimated fetal weight for that gestational age, for that lady, for that pregnancy. Okay. So we will try to calculate EFW. As you all rightly told, I would like to look for AFI and I want to know whether she has polyhydramnios or normal or less lighter. Can less lighter be seen in a diabetes complicated pregnancy?
If it was over diabetes.
Can oligo? Somebody has put it as yes. Okay. Yes, one condition is over diabetes. Then what else? Vasculopathy. Very good. Diabetes with vasculopathy wherein there is IUGR, oligohydramnios, one possibility. Then what else? If it is associated with severe preeclampsia.
Yes.
Correct, no? In preeclampsia spectrum, always it is oligo, IUGR, that kind. In GDM spectrum, it is always poly, macro, that kind. 2 extremes, right? Okay. So you would like to do a USG to know the estimated fetal weight. You want to know AFI and you would also like to know the placental position. Fine. And fetal position also. You would like to know whether it is cephalic or breech because she's obese and her liquor is more. Probably your clinical examination, whether it is right or not, you would like to cross check it with your USG. Okay. And USG we will do once in 2 weeks. And as you said, NST we will do again once in a week. And depending upon what it is, we will also do biophysical profile. Either once a week or once in 2 weeks, depending upon whether she has any complications or not. Okay. Along with this, what she has to do is regular DFMC. That patient has to do. See, always remember in obstetrics, no, you should always give importance to maternal perception of fetal movements because she is the one who is bearing the pregnancy. She really knows how her baby behaves. Okay. So she has been going through that pregnancy like made with 28 weeks, made with 36 weeks, whatever it is, she is carrying the pregnancy. So she knows the pattern of her fetal movements. So never ignore the complaint of reduced perception of fetal movements. It's very, very important. Okay, always give importance to that symptom of your patient. Okay, if she is telling I do not have moments since morning, means hey, I can hear FHS, it's good, go. Don't do that. Okay, give importance to what she's telling. Get a USG done, get a Doppler done, get a NST done before that. Okay, you should reassure her. And following all this, if she perceives her fetal movements nicely, then well and good. Otherwise, she should be under strict surveillance, because reduction in maternal perception of fetal movements is the first obvious symptom to predict that something is going bad.
Yes.
Right? Okay, that is one thing which I wanted to tell. So you got to know, like, you have to monitor her sugar, you have to monitor the mother, and you have to monitor the baby. What are the maternal complications you expect? Generally, in GDM, what are the maternal complications you expect?
Premature rupture of membrane, preterm, preeclampsia, abrupture of placenta, any infections, asymptomatic bacteria, UTI,
Okay.
postpartum hemorrhage in the antepartum or postpartum period.
Okay.
Diabetic ketoacidosis also. Ketone bodies, you have to check urine analysis.
Is more common in overt or in this GDM?
Overt diabetes, type 1 usually.
Now let's discuss from beginning. Like, how do you define GDM?
It's carbohydrate intolerance of variable severity with onset or first recognition during the present pregnancy.
Onset or first recognition during present pregnancy. Very good. Then, do you think an overt diabetes could be first time diagnosed as GDM in the present pregnancy? Can that be possible?
Usually in the early weeks of first trimester, like first when she's confirmed pregnant or first ANC.
Yeah, when her UPT is positive, like by chance if you get a testing done and her values are more, probably she were to be over diabetes, which you have diagnosed it now in pregnancy. So you might have to label her as GDM, but she's actually over diabetes, right? Yes or no? Okay, and you were telling me 24 to 28 weeks is the commoner time where a patient develops GDM. Why is it so?
Because insulin resistance is maximum during that time. During 24 weeks.
What's the process?
The fetus, it derives all the glucose from the mother, and there is insulin resistance so that the blood glucose level does not decrease. And during that time, during first trimester and second trimester, there's also buildup of fat deposition, and then because of main reason is that so the blood glucose level doesn't drop, it doesn't go to metanesis, it can go to the fetal cells because it is completely dependent on the mother for the glucose caused by human placental lactogen, HPL.
Yeah, I wanted the reason why basically pregnancy is a diabetogenic state, or why pregnant women are more prone for diabetes, because of increased human placental lactogen, okay, which acts against insulin. Then what else? Increased estrogen and progesterone,
and even cortisol, prolactin also.
What are the 4 things which are important and which are contributing to the development of GDM?
HPL, estrogen, the hormone-wise HPL mainly, then estrogen, progesterone, cortisol, and even prolactin contribute to increase the insulin resistance.
Whatever insulin is synthesized by the mother is destroyed by something in the placenta.
I don't know.
There is, yes, very good. Somebody has put it rightly. Placental insulinase. Okay, there is some enzyme called placental insulinase, which is secreted by the placenta. How much our mother is trying to cope up, the insulinase is destroying the insulin. That is one more reason where maternal hyperglycemia is not getting into control. These are all the reasons when exaggerated will lead to your GDM. Correct? Okay, good. That's the reason usually GDM develops in second trimester. Okay, coming to screening. Now you are a gynecologist for a moment. Now a patient has walked into you. Do you think in first trimester, for an Indian scenario, you would like to test her for, you would like to get her screened? Yes, ma'am. No, ma'am.
Because, like I said, yes, ma'am.
Yes.
Because of the ethnicity in India, universal screening is followed.
It's always
So as soon as it's confirmed.
Factors because of the ethnicity, as you told, it's always better to screen every pregnant woman in her first antenatal visit, irrespective of the time she visits, irrespective of the gestational age she visits. Okay, very good. That is first thing. That's why I'm not discussing about your high risk woman, middle risk woman, low risk woman, because that doesn't matter. I would like to screen every pregnant woman. Okay, so when do you, like you are a gynecologist for a moment, when do you like to screen? First trimester, second trimester, third trimester?
When first pregnancy is confirmed or first antenatal checkup, that time only.
Her first visit to you,
normal,
you would like to get a test, correct? In her first antenatal visit to you, like if she comes to you in the first trimester, you would do it then. If she comes to you in the second trimester, you would do it then. Am I right? Okay, a good patient. She is coming to you as soon as her UPT is positive, or say around 8 weeks. Do you like it to? Would you like to get it done? Would you like to
check the random blood sugar, fasting blood sugar, and HbA1c? Just check those three. Because 75 oral glucose tolerance test is not possible. They have nausea, vomiting.
Very good. Okay. So you would either do it by any of the methods, as you said, you would like to know it by RBS or HbA1c or even by FBS. Okay. Or even you can go directly for a one-stage DIPSI, like what we follow in India very widely. In all our clinics, what we do is we give a 75-gram glucose irrespective of her fasting status or a meal status. Okay, that's easier for the patient, convenient. No? Okay. So there are so many methods. I mean, there are many guidelines for screening. So let's not discuss everything as it's not a theory class. What is the thing which you would like to follow in an Indian scenario?
It is DIPSI method, DIPSI guideline. That is diabetes pregnancy studies group of India. It says 75. It's 75. There's only one step approach. That is 75 oral glucose tolerance test. 2 hours oral glucose tolerance test. So the woman, like, she doesn't have to be in a fasting state, irrespective of the state. Give 75 grams of glucose in 100 ml of water over 10 minutes. She has to consume. And post 2 hours, the blood test is checked. If her value, like, it's between 120 to 139 milligram per deciliter, then she has gestational glucose intolerance. If it's over 140 to 200 milligram per deciliter, then it is gestational diabetes mellitus. Then if it's over, then we can diagnose as over 200 milligram per deciliter, 2 hours post-pregnancy.
Very good. Very good. Now the same patient has come to you in first trimester. You have got her this thing done, DIPSI done, and her value is probably around 135. Do I have to worry about it?
Yeah, ma'am. It's in the gestational glucose intolerance. So repeat the test at 24, 28 weeks, and then.
Very good. So she is in the range of DGGT. I mean, impaired gestational glucose tolerance or decreased gestational glucose tolerance. Okay. So she might develop GDM. Or one more thing, what I'm worried is people who have this value less than 140, more than 120, they're more prone for developing polyhydramnios later in the gestation. That is one reason I would like to keep her under my surveillance. And as you have rightly told, like, you would again repeat it in the second trimester, irrespective of the value. Even if it were to be normal, you would have repeated it, right?
Yes.
If it were to be normal, whether you have repeated it or not, you would have repeated it, right? Okay. So, and Now, this same patient, take it as value is somewhere around 250. Same
during the first trimester.
patient, in the first trimester, her value was 250.
It's I would diagnose as over diabetes and start
Absolutely.
her on insulin therapy, medical nutritional therapy or oral hypoglycemic drugs won't work for them, and they're
Very
at the
good.
increased
You
risk.
like to know about her HbA1c status?
It tells about the fetal anomalies with
So
over
higher
diabetes, higher risk.
HbA1c, more the chances of abortion, chances of congenital abnormalities, which no mother wants. Correct? Nobody wants an abnormal baby, right? Everybody wants a healthy baby. Correct? So I would like to, if at all your reading is abnormal, I will directly go into HbA1c to know what is her gestational, what is her glycemic status in the previous 2 to 3 months. Okay, because that is the peri-conception period for her, right? So if it were to be somewhere around 6.57, I'm a little relieved. She still has a higher risk of congenital abnormalities, but it is way much better than having a value of more than 10, right? Higher the HbA1c value, they are more prone for having babies with congenital abnormalities. Correct? Okay. And I will treat it as overt diabetes mellitus. Overt diabetes mellitus is more dangerous than your GDM. Okay. Then, now, because we are in the investigation stage, let me complete the investigations there only. Well, now I know that she's over diabetes. I have got a HbA1c done. It's probably around, I'll take it as 6.5. Somewhere a reassuring one. You have, and one most important thing in managing a woman with diabetes, diabetic woman with pregnancy is, it's always multidisciplinary approach. You alone don't do everything. You take endocrinologist in loop or a diabetologist in loop, and also a very good neonatologist in loop along with your obstetric care, right? Okay. So what else investigations would you like to order for if you have diagnosed her as over diabetes mellitus in first trimester?
Urine analysis to check for ketone bodies,
Would like to
proteinuria,
know
or
for
infection.
urine routine. You would like to screen glucose in the urine routine. Also, you would like to look for urine proteinuria. Correct? Proteinuria.
And even thyroid.
You would like to do thyroid abnormalities then.
And then even thyroid.
Yes, then.
Filing.
Very good. Somebody has rightly put it as RFT. I would like to know what is a renal function test. Whether she has an abnormality or the kidneys are functioning well. She, if at all she has some renal pathology, she can also develop superimposed preeclampsia. No. So, which makes her to fall into very higher risk. If any of them is there, I would like to treat it now only. Okay. Don't you think I would like to also look for a fundoscopy?
Yes.
Okay. And you should also advise her for ECG and echo to look for her cardiac status also. When you know she is over diabetes, whatever is her age, always have a baseline investigations because you don't know how she progresses. She can develop any kind of complication, correct? She can develop vasculopathy, she can develop preeclampsia, she can develop renal problems, she can have proliferative retinopathy, she can have any kinds of end organ damage. So always have a baseline investigation as soon as you diagnose her over diabetic woman in the first antenatal visit. Okay, now again, coming back to baseline. Now your patient, normal screening test in first trimester. She is a regular patient to you. She has come to you in second trimester. What do you do?
Again, repeat the one-step Dipsy method approach.
Very good. You will again screen her by one-step Dipsy method. When?
Like 24 to 28 weeks, whenever she's come. Usually they come once a month up to 28 weeks. So anytime beyond 24 weeks.
Between 24 to 28 weeks, sometime you would like to do. Now say her GT, the value was around 148. What do you do?
140. Advise medical nutritional therapy for 2 weeks, and then check blood test after that. If after 2 weeks, if it's more than 140, then start start with insulin plus medical nutritional therapy. If it's within the normal range, then she can continue her medical nutritional therapy. She comes very late in the trimester, then no medical nutritional therapy, direct insulin close to the.
So what do you want to keep her PPBS cutoff as in medical nutrition?
The targets, yeah, the fasting blood sugar
On postprandial.
Postprandial up to it's if it's 1 hour postprandial, then it's 140 milligram per deciliter. If it's 2 hours postprandial, then 120 milligrams per deciliter.
I would like to tell her, like, if your PPBS is less than 120, we will continue on diet only. And in our practice, we have seen many patients who have very good control only with lifestyle modification and MLT. Okay, a well-informed patient is important, and a good nutritionist is important to you, who gives the right advice, who keeps a track of her diet, who advises accordingly. Fine. Okay, so you should also loop in a good nutritionist while caring for such women. Okay, that is one thing which I wanted to tell. So we have covered MNT, and as you have rightly told, if following 2 weeks, if MNT is not able to control her blood sugar levels, you will go for medical management. I mean, pharmacotherapy, either insulin or metformin, depending upon what this patient wants. Do you think in your profile, metformin would have done a good job if it were to be started in second trimester? Because she has not taken insulin.
Yes.
Probably if she, when as soon as she diagnosed,
yeah, metformin also would have.
If probably she had been under regular
Easier to
follow-up
say.
in second trimester only, if she had been in your regular follow-up, if she had told you that she is not taking insulin, probably, then if we had started the metformin at that point of time, probably it would have been a more better prognosis than what she is now. Correct? Okay. So now you got to know about MNT, and as we already discussed, 3 major meals, 3 minor meals, and we also got to know calorie distribution and different component distribution, and we got to know what kind of carbohydrates she has to take, and she has to take high fiber diet and also less than 10% saturation fatty acids. Don't you think along with MNT, physical exercise is one of the important key?
Yes.
We have to advise that. Only MNT will do nothing. No good job. It's always hand in hand. You have to advise lifestyle modification in terms of brisk walking for 30 minutes, at least 5 days a week. Saturday, Sundays, rest days, no, for everybody. Okay, fine. So, weekends, you can give her off 5 days a week. You should keep a track of it. Fine. Majority of them respond really well. Okay. Now, how do you monitor her? Okay, now she has come to you in second trimester. Like, for all practical purposes, we'll take it as she has responded well for her MNT and lifestyle modification. How will you monitor? How will you take on the pregnancy?
Yeah,
you will keep monitoring.
Continue self-monitoring.
Okay, self-monitoring.
She can
you
continue
will
self-monitoring the blood glucose level. And then it's only second trimester, so she can come for a next visit in third trimester. Like, usually, they're usually hospitalized beyond like 34 weeks or 36 weeks. Before that, because she's already keeping it under control and following, like she's compliant with the advice, she can continue with self-monitoring and seeing if it reaches.
So what are the 2 important fetal surveillance methods which I would like to do in second trimester?
The USG and the.
I would like to get a
TIFA scan.
I would like to get a detailed TIFA scan. Yes or no? Anomaly scan.
Yes.
TIFA stands for Targeted Imaging for Fetal Anomalies. I would like to get a TIFA scan in a very good center. Yes or no? Okay, first thing. And second thing, I would also like to do a fetal echocardiography at 24 weeks of gestation. Correct? Especially more relevant if she were to be a over-diabetes. Okay, so what are the congenital abnormalities you expect in a diabetic mother?
Most common is cardiac anomalies. In that, transposition of greater arteries and ventral septal defect. Most specific is neural tube defect, caudal regression syndrome, also known as sacral agenesis. Other than that, there can be musculoskeletal, urogenital, even anomalies. That's it.
So what is that neuromuscular abnormality which also contributes to your polyhydramnios? Okay, what are the causes of polyhydramnios?
Because of hyperinsulinemia. So one thing is the amniotic, it might be irritation, so it's secreting more fluids, and also polyuria in the yes, ma'am.
Irritation.
Polyuria, irritation of the amniotic sac. It increases the secretion, so it secretes more. Another
Okay.
thing is polydipsia, increase the like polyuria in the fetus also can lead to increased amniotic fluid.
So what one thing what you told is amniotic epithelium irritation. Then increased polyuria by the baby. Then
Placentomegaly also.
placentomegaly. Somebody has rightly put it as placentomegaly. Correct. So these are the main things how polyhydramnios develop. What are the fetal complications? Okay, other than congenital abnormalities, now we have told. Okay, and this meningomyelocele, if at all they are present, they will also cause increased transudation. No, they also contribute to your polyhydramnios. Okay, other than congenital abnormalities, what else are the fetal complications?
Delayed lung
Rahul,
maturity.
No, Rahul is asking something. I'll come back to you, Rahul. Okay, so what are the fetal complications you expect?
Macrosomia, delayed lung maturity, and even IUGR, like if in case of over diabetes.
Associated with vasculopathy or preeclampsia, especially then.
And even shoulder dystocia.
Then birth injuries because of your shoulder dystocia.
Yeah.
Birth injuries.
Erb's paralysis, like brachial plexus injuries, birth injuries.
Then spontaneous abortion. Somebody has rightly put. I was looking for it. Like if we go trimester wise, first trimester we expect one of the most common cause of first trimester abortion is your spontaneous abortion. Is your diabetes, over diabetes, which was undiagnosed. But when you try to evaluate the lady, that is when you get to know that the patient was diabetic and her HbA1c was somewhere skyrocketed. Fine. And congenital abnormalities, as you said, macrosomia, prematurity, shoulder dystocia. Don't you think sudden IUD is one of the important complication of diabetic mothers? That is the reason why ask for daily fetal movement count, right?
Yes.
Why? What is the mechanism behind that?
Because of this increased glucose, there's increased water absorption, and it leads to hydropic edema, the placenta, and then the amount, like whatever is reaching the fetus, it reduces, and then that might lead to stillbirth.
Okay. What are the neonatal complications?
Neonatal hypoglycemia, then hypocalcemia.
I don't understand one thing. Why there is fetal hyperglycemia and neonatal hypoglycemia?
Once the neonate is placenta, it's separated from the placenta, but still there is that hyperplasia of the fetal beta cells, hyperinsulinemia, and that decreases the glucose level in the the neonate. So there's neonatal hypoglycemia. Before that, it was receiving glucose from the mother.
Good. Audience and presenter, both are good. Then hypoglycemia. Then, so very, very importantly, whenever a baby is born, you know that it is macrosomia. See, for a visitor, how it looks. The baby is chubby. The baby looks like a teddy bear. The baby is so cute. Along with that, you should also warn the lady that feed again and again. The baby can keep the baby warm. And look for baby again and again, irrespective of whether it asks or not. Keep feeding. Have the hypoglycemia in mind. Okay, it is not just being happy about being chubby. It's also that you have to counsel her a little more than any other patient. Okay, because they don't know that the baby can go to hypoglycemia. They will think that baby is not crying. That's why I have not fed it. Irrespective of whether baby asks or not, again and again you have to advise the lady to feed. Okay, so hypoglycemia, hypocalcemia,
Hypokalemia also.
hypomagnesemia,
Hypermagnesium.
hyperbilirubinemia. Why? Neonatal distress, very good. That is one important respiratory distress, one of the major complication, no? It can lead to birth asphyxia. Okay. And neonatal sepsis can happen because the baby is more prone for infections. If the diabetes was not to be controlled in the mother, she can have PRM, chorioamnionitis, and followed by neonatal sepsis. HMD is same as respiratory distress, no? Somebody has put it as HMD. Okay. What is the mechanism of your hyperbilirubinemia? Okay, very good. Somebody has rightly put it as the baby can have polycythemia because of the chronic hypoxic environment. What you told is the mechanism for IUD. Don't you think the body's protective mechanism is polycythemia? Okay, because increased blood RBCs are means increased destruction of RBCs also, and as such you are delivering her at around 37-38 weeks. So it is beyond the capacity of the liver to clear all the bilirubin. So the baby is prone for hyperbilirubinemia. It's a sequel of your polycythemia, correct? Then this baby is also more prone for developing diabetes mellitus early in its life. Okay, so what is the mechanism of congenital malformations in a overt diabetes mellitus lady?
Because they have, like, the blood glucose level is high since first day of gestational period. Free radical formation, that because organogenesis is also taking place, so it increases the congenital malformation and even risk of abortion.
First thing is free radical injury. Also, it can be because of your abnormal embryogenesis, and it can also be contributed by hyperketonemia and decreased arachidonic acid and myoinositols. All these things are contributory factor for the development of your abnormal babies or congenital abnormalities. Okay. Now, too much of discussion or too much of audience are very interested in preterm labor. So I'll directly go into preterm labor. Why do you think preterm labor is more common in GDM women?
Because of premature rupture of membrane, polyhydramnios.
Contributory factor is PROM. Then
this polyhydramnios also.
Very good. Polyhydramnios, over distension of the uterus. So premature activation of the axis, and more prone for your preterm. Very good. Somebody again, macrosomia. See, when there is over distension of the uterus beyond its capacity, it thinks that it is term. Correct? It doesn't know. It can't calculate the gestational age. No. Okay. Okay. I'll come back to preterm labor. Now, I wanted to ask something. Yeah. Okay. Anyways. So as such, lung maturity is little less in the babies born to, in IDA, means infant of diabetic mother, when compared to general children, general other babies born at the same gestational age, correct? So if at all the baby is born prematurely, it will have more RDS as compared to baby born to infant diabetic mother, correct? So preterm babies are more prone for neonatal complications or perinatal mortality and morbidity in these kids when compared to kids or babies born in to a normal mothers of a similar gestational age. Okay, that is why role of corticosteroids is very, very important, and it is like a double-edged sword. When you give corticosteroids, again there will be alteration in the blood sugar levels. That's why we admit the patient. That's why we admit the patient, monitor her blood sugars, and increase the insulin dose accordingly. At the same time, we are also giving corticosteroids because for us, lung maturity is very, very important. Somebody was asking, if there is PRM, what will I do? What will I do depending upon the gestational age? I will look for a good neonatal care. That is what is important. Delivering is easier job. You can do, I can do, anybody can do. And delivering a smaller baby is more easier, correct? Because the given pelvis will be good only for the average size baby than a macrosomic baby, correct? No. So first thing is, I will evaluate the mother. If her general condition is good, and I will get a CBC done. If her CBC has normal counts, I'll get a CRP done. If it tells me that there is no active infection, I will, after examining her, like I will look for per speculum examination, per vaginal examination, gestational age, fetal surveillance, everything. If every parameter is good, I will keep her under observation. I will give her a dose of antibiotics. I will give her a dose of corticosteroids, and then I will induce her for labor. If provided this PROM does not subside on its own. Sometimes, when you keep her under observation, most of the times, if there is a small leak, it seals off. If it doesn't seal, then I will go for induction of labor after giving corticosteroids and after giving her an antibiotic coverage and after having a very good NICU setup. If I don't have a good NICU setup, I will refer her in utero. Means I will not deliver and send the baby, because basically this baby is prone for RDS, also hypothermia, right? And also sepsis. Rather than delivering the baby and referring it to a higher center, send the baby in utero to a higher center which has all the facilities. Don't just think about your competence as a doctor. You might be an excellent doctor. Think about other factors needed for the good outcome of the mother and the baby. Always. Okay, you have that attitude always, not just related to obstetrics, related to every branch, whatever you take in the future. Always look for the patient's outcome. You might be excellent, but there are limitations around you, right? Okay. That is how I would like to manage my PROM case. And if there is any evidence of chorioamnionitis or anything, then I will not wait till the baby or the mother deteriorates. I will deliver then and there, explaining all the, taking a detailed consent by the mother and the attenders. Okay. Somebody has asked this question in this chat box. Okay, what is the mechanism of macrosomia? We are talking so much about macrosomia. Now, what is the mechanism of macrosomia?
Same, like chronic hyperglycemia in mothers. So there is hyperglycemia, fetal hyperglycemia. And then same hyperplasia of the fetal fetuses, hyperinsulinemia. And there is like increased fat, this one deposition in the shoulder and abdomen in the fetus. So,
okay. So very good, very good. I mean, all of you have really put very good inputs. Pedersen's hypothesis, hyperglycemia leading to hyperinsulinemia, lipogenesis, protein synthesis, carbohydrate synthesis, and everything leading to increased FFP, increased triglycerides, and hence adipose tissue formation. Despite having good amount of fat, why do you think these babies are more prone for hypothermia?
Increased body surface area.
Baby is chubby enough, no? Okay, first question. Do you think these babies are more prone for hypothermia than other babies? True or false? True, because I have already told, no?
Maybe brown fat is less.
Brown fat is less. These kids have more, these babies have more yellow fat. Okay, these babies have more yellow fat than brown fat. That's why these children are more, these kids are more prone for hypothermia. And one more thing, like now, I'll give you an example. There's a patient A and a patient B. And patient A is a normal lady with a 3.8 kg baby. Patient B is your patient, which has a 3.8 kg, 3.6 kg baby. Same in both. Second patient is your patient, which is around 38 weeks. Okay. Which of these babies is more, both the pelvises of the mothers are same, both have similar BMIs, everything. Which do you think has a more...
38, like, can you repeat once?
Patient A and patient B, both are 38 weeks of gestation. Both are primigravida. Both have similar EFW, 3.8 kg baby. Both have borderline pelvis. Okay, both have, we still don't know whether it is, for CPD, no, the measure is delivery. If the baby delivers, no CPD. Okay, so both have a relatively good pelvis. Which amongst these two, second patient is your patient. First patient is my patient. Okay, second patient is your GDM patient, which you have managed and brought till 38 weeks, and you have induced her. Which of these two patients, A and B, are more prone for having shoulder dystocia?
Both have GDM, or only one person has?
No. A patient A does not have a GDM. She is a plain, no high risk factor.
B is more prone for shoulder dystocia.
Why? Why? Both are 3.8 kg baby only, no?
Yeah, but there's more of fat accumulation in the shoulder and the abdomen and
Very good. Deposition of the fat in the shoulders is more. Okay, that is why the shoulder dystocia happens. That comes off easily, and then you have difficulty in delivering the shoulder. Fine. Okay, that is one thing. And whenever you are looking, whenever you are doing antenatal scans, you should always look for the abdominal circumference, which will give you a fair idea of whether there is macrosomia or not. Okay, anything above 90th percentile for that given gestational age is macrosomia. Okay, now your patient, she is there, she will come and tell you, madam, I have made a mistake. At least I was not compliant. Now I will stay in your hospital till delivery. Okay, so you're coming to the management of your patient proper. 34 weeks, 4 days. Okay, so as you have already rightly pointed out, what will you do? You will admit, you will evaluate, you will look for maternal, diabetic, fetal surveillance, all three. And you will do a multidisciplinary approach. So you're doing NST weekly, everything is fair and enough, fair and good. Okay, NST is good, BPP is good, her perception of DFMC is good, Liker is okay, fine. Weight is also around, probably I'll take it as 3.5 kg. What do you want to do at 38 weeks of gestation? Pelvis, according to you, is good enough. Would you like to induce her?
Induce labor and put for normal vaginal delivery.
Would you like to induce her for cesarean section because she has diabetes?
No, ma'am. The cesarean
Two
section
options.
indication depends on the weight of the baby because it's below 4.5 and pelvis is also at
0.5. I told you.
No, yeah. For her, normal vaginal delivery is fine for this patient.
You can try induction of labor. When do you want to do that? 38, 39, 40, 41?
Yeah, normal vaginal delivery, not C-section.
Okay, when do you want to induce her labor? 38, 39, 40, 41?
38 weeks. If she has...
Very good.
Oh, yeah.
So?
Not a comorbid condition, okay. So... Yeah.
Your patient does not have any comorbid condition, so you would like to give a trial of vaginal delivery by inducing her at 38 weeks. At the same time, you should always have a emergency cesarean section facilities, correct? If I don't have a cesarean section facilities, emergency cesarean section, please do not induce her, fine. And if she were to be a patient who had a good control on MNT, medical nutrition therapy, along with that a good lifestyle modification, till what gestational age would you give a trial?
Up to 39 weeks. 39 to 40.
You can even take her if she has good control by diet and physical exercise, and if all the parameters are doing good, you can take her till 40 weeks. Okay, I'm not discussing about criteria of diagnosis and what values. All that itself is a tedious class. So I want to give a general overview. That's the reason I'm not taking all those values and confusing you people in this class. Okay, so you will have a fetal surveillance, and in every antenatal visit, you will check her BP of the mother because she's more prone for developing. You will look for weight gain and BP along with her obstetric examination. Correct? And symphysiofundal height and abdominal circumference will give you a crude idea about whether she has polyhydramnios or macrosomia or what. Fine. And along with that, as we already discussed, we'll do USG. We'll ask her for frequent antenatal visits. From 32 weeks, we'll start NST, BPP, USGs every 2 weeks with fetal Dopplers, SOS, depending upon the coexisting conditions. Right? And now, as we discussed, we will take her till 38 weeks in your case and induce if you think that her pelvis is doing good and if you have a good round-the-clock surgery facilities. Fine, emergency cesarean section facilities. Would you like to give pain analgesia for her?
Epidural, yes.
Yes. If at all you have a facility for epidural analgesia, please give that. Okay, please give it. Not everybody are fortunate enough to have that painless delivery system, but if you have that, please give that. Okay. Would you like to give her a morning dose? Now you have planned that she's going to get induced tomorrow. You have already given a steroid coverage and baby is doing good. Would you like to give her a morning dose of insulin? Today morning, tomorrow morning, you're trying to induce.
No morning dose of insulin and no breakfast also.
No morning dose of insulin. Fine. You will not give morning dose of insulin. You will have a buffered system. You will add insulin in the DNS and you will keep her under, keep a continuous flow. You will keep her NBM or you will give her clear liquids depending upon how the pelvis is, how the fetal condition is. And you will monitor her blood sugars regularly. I mean, every hourly till she delivers. Correct? Right. Before that, no, I just want to give a overview of how will we do self-monitoring of blood glucose for the benefit of everybody. You will ask the patient to have a fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner and post-dinner daily till her insulin is titrated and her sugars are well in control. Once it is well in control, you can do it 2 days a week. Okay. So usually you would like to keep fasting less than, what are your goals? Fasting less than
5 milligram per deciliter, less than 95.
You have started her on insulin. What are your targets? How do you want to?
Yes, ma'am. Fasting blood sugar less than 95 milligram per deciliter. 1 hour postprandial less than 140 milligram per deciliter. 2 hour postprandial less than 120
Okay, then
and HbA1c less than 6.5%.
See, whenever you are monitoring the patient, have one value. Whenever you are monitoring your patient, have one value. Always know, post breakfast 1 hour, post lunch 2 hours, post dinner 1 hour. Don't do that. Have one value. Educate her for one value. Either 1 hour or 2 hours, whichever she and you are convenient with. If you are doing for 1 hour, take the cutoff as 140. If you are doing for 2 hours, take the cutoff as 120. We do it here for 2 hours. Okay, it depends. It depends. It's your convenience. Okay. Then, as you rightly told, pre-meal should be less than 100. Fasting should be less than 97. So, fasting, as soon as she gets up with 8 to 10 hours of fast, her RBA should be less than 95. So, again, I will again, to just avoid punctures, we will again not ask her for pre-breakfast. We will directly go for post-breakfast. 1 hour or 2 hours. 1 hour, 140 is my target. 2 hour, 120 is my target. Pre-lunch, it should be less than 100. Post-lunch, 1 hour, 2 hour, 140, 120. Again, pre-dinner, same. 100, 140, 120. Pre and post-dinners. Fine. And once in a while, you will also try to check her, because she is admitted with you, you can do her between blood sampling between 2 and 4 a.m., which should be between 60 and 90. I'll tell you why you have to do that. If she's at home doing her self-monitoring of blood glucose, you will not disturb her, telling that do between 2 and 4 a.m. She will start scolding you. If she's in hospital, ask your sisters to do between 2 to 4 a.m. monitoring. Fine. Not daily, once or twice till she delivers. Okay. And what are the insulins which we prefer? We prefer intermediate and regular acting with additions of your rapid acting. Okay. Intermediate insulin. First, you will try to calculate the dose depending upon the trimesters and depending upon the body weight. Once you calculate the dose, you will give the insulin in divided doses in a combination of 70:30. 70 is your intermediate acting, 30 is your short acting. Fine. Night, you can either give 70 or you can either give 50-50. 50-50 combination, I'm telling. 50 intermediate, 50 short acting. Depending upon how the values turn out, you will add rapidly acting, means fast acting, very fast acting. Either depending upon which value is abnormal, you will titrate it. That much is not needed for your level. You just understand that we have to give insulin in divided doses. We usually give a combination insulin, combination of intermediate acting and a short acting insulin in the combination of 70:30 in the morning, 50 to 50 in the evening, 2/3 of the dose in the morning, 1/3 of the dose in the night of whatever you have calculated. Got it?
Yes.
Depending upon which value is abnormal, which value you want to control, whether it is post-lunch, post-dinner, or fasting, we try to titrate it, adding very rapid acting insulins in between. Too much, no?
Yes.
Okay.
No.
How is insulin given? How is insulin given?
To the
IMIV?
intramuscular.
Intramuscular.
This is subcutaneous.
See the answers pouring in.
Subcutaneous, ma'am.
Subcutaneous. Never make mistake with the route. Okay. It's okay if you don't tell the dose, but you should never tell the wrong route. Insulin is standard. It is subcutaneous. Fine. Only we give IV infusions during delivery. Otherwise, it's standard. Okay. So you give subcutaneous, and first trimester you will give around 0.7 units per kg. Second trimester 0.8 units per kg, and third trimester 0.9 units per kg. All that is not needed. Remember 0.7, 0.8, and 0.9 per kg body weight. Okay. This is how we calculate insulin. It is little too much. Anyways, endocrinologist will take care of it, but you should know the cutoff values. Once it is abnormal, you can again talk to them and they will titrate the dose. Okay. And in your case, she has delivered. What do you think will be her blood glucose values following delivery? Will it come back to normal or will it be high again?
Normal. Like if it's gestational diabetes mellitus,
Very good.
6 weeks postpartum, it comes down. If it
In
was
your
over,
case,
then
I
we
don't very
confirm.
clearly in your
Oh, yeah.
case.
6 weeks postpartum, it would have reduced. Come back to normal range.
The first 24-48 hours only, the requirement of insulin drops from drastically because the plasma itself is gone. The pathology is gone. Correct? Most of till now, whatever GDM cases I have seen, no, none of them required insulin post-delivery. GDM cases I'm talking about. Okay, none of them required. So, but why are we worried? Because few of them can continue like that as type 2 diabetes mellitus. That's why I have to monitor her. I will do once at 24 hours, once at 48 hours, and 6 weeks postpartum. Some can continue as type 2 diabetes. Few of them will resolve just to come back again as GDM in the next pregnancy. Okay, that's the reason we should know whether she has GDM in the pregnancy or she has GDM now. Okay, because they tend to recur. Okay, and why is this phenomenon important? I mean, why is that nocturnal blood glucose important to me? It is just out of interest of few people I'm asking. There is something called dawn phenomena and Somogis phenomenon. Okay. Okay, I'll just tell off. In both the phenomena, FBS is high. FBS is high. Usually, what should happen in pregnancy? FBS is low, postprandial is high. Generally, lady will have a fasting hypoglycemia followed by a postprandial hyperglycemia. That's a normal physiological change of pregnancy. But here in dawns and Somogis, what will happen is FBS is high in both. How should I know whether it is dawns or Somogis? Is when I do a nocturnal thing between 2 a.m. and 4 a.m. If it is high, then it is dawns phenomenon. If it is low, then it is Somogis phenomenon. Okay? If it is dawns phenomenon, wherein USMLE and FBS both are high, I will increase her insulin in the night dose. If it is Somogis phenomenon, where her nocturnal is less, I will reduce the dose because she had a hypoglycemic episode in the night for which body reacted briskly, causing increase in FBS. So what I should do? I should avoid that nocturnal hypoglycemia. What should I do to avoid that nocturnal hypoglycemia? I should reduce the dose. Clear? Is it clear? I mean, you might not need so much. Okay, now coming to labor proper, which is your management proper. 38 weeks you will induce. You will induce either using prostaglandin analogs or by using oxytocin, whatever is your institutional protocol. You have to monitor the delivery by a partograph. That is must. And you should have a continuous electronic fetal monitoring using that CTG machine. Okay? Because the baby can go into distress anytime. Okay? And you should always be prepared for a difficult delivery. You arrange blood. You keep call for help ready, because she can land up in a PPH, or you can even need somebody's help to deliver a difficult shoulder. And you know that in your case, she's a primary gravida. There is no trial of pelvis happened previously. Correct? So be a more flexible. If any slightest amount of doubt, take her for cesarean section. Give a good healthy baby to her with the help of a good neonatologist. Fine? Now I think all the audience can ask your doubts. There are too many doubts, yeah? Okay, now come back with your doubts. Let me clear all of them. I think I was given only time till 7:30. Now already we have passed a lot of time now. What's the time now? It's 8 o'clock. Kishan will start telling me now. Okay, now I will either take one or two doubts. Audience can fastly put it in the chat box. You can fastly put it in the chat box. Like, I'll just take one or two doubts. See, when the class is going on, so many doubts I get. Now, ma'am, in case of elective cesarean section, what's the Trishma? When can it be done, ma'am? Same 38 weeks. If she's on insulin, 38 weeks. If she's over diabetes mellitus without any complications, 38 weeks. If she's over diabetes mellitus with any kind of complications, depends upon the gestational age, after steroid coverage, anything, depending upon the seriousness of the condition. Okay. And in case of GDM, well controlled on MNT, I will take till 40 weeks. Single step or double step screening. I always prefer single step screening because patients are already coming from far distances. I don't want them to come fasting. I don't want them to come again and again. So single step. So single step, 75 gram glucose as advised by DIPSI. Fine. DIPSI, single step, 75 gram, irrespective of fasting status, 140 is the cutoff, as you have rightly pointed out before. Then,
ma'am, excuse me, ma'am. Ma'am, there's a session at 8 p.m. So
can we wind up?
Okay, ma'am. Ma'am, any concluding remarks regarding the session, ma'am?
Yeah, Tanusha, you have really presented well. You have been relatively well prepared for this thing. Good job. All the very best to your career. And basically, no, all the audience were very interactive this time. I'm very happy about the crowd.
Thank you so much, ma'am. Thank you so much.
It was helpful to you guys. Yes or no?
Yes, ma'am. It was very helpful, ma'am. We could learn a lot from this session. Thank you for taking your time and joining us today evening and taking this session, ma'am. Thank you so much too.
Sorry, I have too many disturbances this time because actually, I'm getting too many hospital calls. Sorry for all the disturbance.
No problem.